Hello, everybody, and welcome to our module on NSTEMI and unstable angina. Let's start by talking about NSTEMI, which stands for non-ST elevation myocardial infarction. And it gets this name because this condition is a myocardial infarction. There's ischemic damage to myocardial tissue, but there are no ST elevations on the EKG. And by way of review, what causes an NSTEMI is atherosclerotic plaque rupture and thrombus formation. This is a drawing of how you can think of it in your mind. There's a lipid-laden plaque. It ruptures and a blood clot forms on top of that, and that obstructs blood flow. But importantly, in an NSTEMI, the occlusion by the plaque and the thrombus is subtotal, meaning less than 100%. So some blood can flow past the obstruction. The blood flow is simply limited. And the symptoms of NSTEMI are ischemic chest pain. So what do I mean by that? It's classically a squeezing pain in the middle of the chest. And importantly, it will have an unstable pattern. That's what differentiates NSTEMI from things like stable angina. So the patient may have had chest pain in the past, but when they develop an NSTEMI, they'll report that the chest pain is occurring more frequently, that the symptoms last longer, and the symptoms can be present with minimal exertion or even sometimes at rest. Patients who are having NSTEMIs can have rest chest pain, and that definitely makes it very different from stable angina, which I talk about in another video. So as I already mentioned, the occlusion in an NSTEMI is subtotal, meaning there is some limited distal flow. And the area of infarcted tissue is usually in the subendocardium. I discussed this in detail in the videos on cardiac ischemia, but usually it is not transmural damage to the wall, it's subendocardial damage. And because the ischemic area is subendocardial and not transmural, NSTEMI has unique EKG changes. So sometimes the EKG is totally normal, but when there are changes, you can see ST depressions or T-wave inversions, which are depicted here. But importantly, you will not see ST elevations. When you see those ST elevations, that makes it a STEMI and not an NSTEMI. Okay, so let's talk about cardiac biomarkers. So cardiac biomarkers are elements of myocytes that spill out into the blood when there's injury to the myocardium. And the most commonly used biomarker is troponin. There are two troponins that are measured to detect damage to myocardium. Those are troponin I and troponin T. So when you have ischemia and you develop necrosis of myocytes, troponin will spill into the bloodstream and you can detect it on a blood test. It takes about 2 to 4 hours after the myocardial infarction stops for troponin to become elevated in the blood and detectable by a lab test. And then the troponin level will stay elevated for weeks. And so these two facts here are super high yield to know for your boards. If a patient presents 30 minutes after developing chest pain from an MI, they can have normal troponin because 2 hours has not yet passed. And if a patient had a myocardial infarction a week ago, even though they may have recovered and be feeling well, they can still have an elevated troponin. There's also an older biomarker. It's not used so much anymore. It's called CKMB. This biomarker rises about 4 to 6 hours after a myocardial infarction and normalizes within about 2 to 3 days. So let's talk a little bit more about that biomarker CKMB. So CK stands for creatine kinase, and there are several subtypes of CK found in different parts of the body. So the MM subtype is found mostly in skeletal muscle. The MB subtype, which is what we just talked about on the last slide, is found mostly in the heart, and then there's also a BB subtype found in the brain. Now, most tissues have some of all three subtypes, but what I've shown you here is the predominant subtype in each location. But what this means is that you can see elevated CKMB in many disorders. For example, many muscle disorders that don't involve the heart can present with elevated CKMB. So for that reason, we usually look at the percentage of CKMB as a part of the total CK to detect ischemia. So if a patient has an NSTEMI or some other form of myocardial infarction, there will be elevated CK and most of the total CK will be CKMB because it's coming from the heart. On the other hand, if you have a condition like rhabdomyolysis, which causes muscle damage, you can also see an elevated CKMB, but most of the CK in the peripheral blood will be the MM subtype and not CKMB. So by looking at the percentage of total CK that is CKMB, you can use that to detect ischemia versus muscle damage. Be aware that there is AST, which is a liver enzyme. There's some of it that's found in the heart, and it can spill into the blood with a myocardial infarction. So in a patient who presents with abdominal pain and elevated AST, this could be a myocardial infarction. It doesn't necessarily mean that there is a liver problem. I think it would be super sneaky to ask you a step 1 question about this, but simply be aware that an elevated AST doesn't necessarily mean there can't be a problem with the heart. Okay, let's talk about the treatment of NSTEMI. So this is a thrombotic disorder. There's a blood clot in a coronary artery. It's also an ischemic syndrome. And these two facts are very similar to STEMI. So many of the treatments we use for NSTEMI are the same as STEMI. The biggest difference is, unlike in STEMI, there is no ticking clock. So the occlusion in an NSTEMI is subtotal. So there's still some blood flow to the distal myocardium. So we usually don't need to do an emergency angioplasty or administer thrombolytic drugs that bust up the clot but carry a large risk of bleeding. These things are done in STEMI because it's an emergency. The longer the STEMI goes on, the more damage there is to the heart. That's not the case in NSTEMI. So shown here are some of the treatments that you'll see used. This is very highly technical stuff. It's different in different centers, but in general, aspirin is usually administered. This is to limit the formation of clots in the coronary artery. Beta blockers are often given that reduces the oxygen demand of the heart and can improve ischemia. Heparin's often given also to limit the amount of clot formation. And then finally, angioplasty and stent placement is often done for NSTEMI, but this is usually a non-emergent procedure in contrast to STEMI. So here's an example of what a typical NSTEMI hospital course could be like for a patient. So the patient presents with chest pain. The EKG can be normal, or there may be ST depressions or T-wave inversions, but there won't be ST elevations. And then when you check the biomarkers like CKMB and troponin, they will be elevated. That's the hallmark of an NSTEMI, elevated biomarkers but no ST elevation. Medical therapy can be administered with these things I've listed here. The patient is admitted to the cardiac floor. The next day, they can go have an angiogram, which shows a 90% blockage of the LAD artery, and a stent can be placed. And so you will see this sequence of events over and over again in your third-year clinical rotations. So now that we understand NSTEMI, we can talk about unstable angina. These two disorders are very similar. Like NSTEMI and unstable angina, there's rupture of a plaque and thrombus formation and subtotal vessel occlusion, just like shown here. It's the same pathophysiology for unstable angina and NSTEMI. There's also ischemic chest pain in unstable angina, just like we talked about before. But importantly, the biomarkers like troponin are normal. And that's what distinguishes unstable angina from NSTEMI. It's the biomarkers. They're elevated in NSTEMI. They are normal in unstable angina. The diagnosis of unstable angina is based largely on the patient's history because there are no blood tests you can do. So you need to get a history of chest pain that's occurring with increasing frequency and intensity, or chest pain at rest. There can be EKG changes like ST depression or T-wave inversions, but those aren't always present. And then the treatment is the same as for NSTEMI. It's with all the drugs that we talked about before. In fact, the treatment paradigm for NSTEMI is often called the treatment paradigm for UA/NSTEMI, meaning unstable angina and NSTEMI. And that's because the two disorders share a common underlying pathophysiology and they're treated the same way. So here's a summary slide of the different coronary artery disease syndromes that I show in a number of videos. But in this video, we're focusing on unstable angina and NSTEMI. So in terms of pain, both conditions involve chest pain with exertion or at rest, usually with an increasing frequency or prolonged symptoms. What distinguishes the two syndromes is the CK and troponin, the biomarkers. They're negative in unstable angina, but positive in NSTEMI. Both conditions can have the same EKG changes, ST depressions, and T-wave inversions, although these aren't always present. And then there's no area of infarction in unstable angina, but in NSTEMI, the area of infarction is subendocardial. They're both associated with rupture of a plaque and clot formation and occlusion of more than 75% of the vessel, but importantly, not 100% because that's what leads to STEMI. And that concludes our module on NSTEMI and unstable angina.